me? Okay, Dr. Marwa, are you ready to join? If you would like to join us in this. Yes. If there is anyone to want to join us, we will be like feel free, tell anything it's fine. I mean that at least we can see something here. So any participant from our great participant want to join us?
Okay, I will join.
Yeah, please, yeah, thank you. So let's have like I will make scroll for you and try just to describe. As you know, we mentioned before that the most important when you have a look in the neck to describe where you are in which neck space, then probably you have the key that you have differential diagnosis. Then after that you can so what, let me be silent now and you can talk. Yeah.
And there is a filling defect or right internal jugular vein.
Yeah, this is the key, and you get it very quickly, and this is very, very nice, because when you look in the neck space, yes. Yeah.
There's also hypodensity in the retropharyngeal space.
Yeah. Exactly here, yes.
Okay, extension more inferior.
Yeah.
I think it is enlarged with filling defect.
Exactly, yes.
Yes.
So I feel that you wanted to ask me, so maybe shift it for the venography, as I think you would like to see it, right?
Okay.
So you see that maybe there is something abnormal going in the venous phase, right? I'm checking with you, like every single phase here, and trying to interpret it with you. Okay. So you
absent
mentioned
of the flow.
Yeah, exactly. So
within the right internal jugular vein.
Exactly. So what would you like to put in differential diagnosis as?
It is either retropharyngeal abscess or any kind of infection that causes this thrombosis.
Yeah, exactly, yes. So exactly. So this is one of the most important things in the exam, that you put a differential, and as many people mention, that it could be, as you mentioned, Lemierre
syndrome.
Yes, exactly, Lemierre syndrome.
But Lemierre syndrome, I should have a septic emboli in the lung.
Exactly, yes. So this is the tricky case. Maybe here they don't have lung window, or maybe if they shift this one in the lung window, we can see something in the lung, but they don't show us in this case. So what I want to tell you that your approach is very nice, because you mentioned that you want to see the chest. So next step that you want to shift and see if there is patient
lung window.
Exactly. Either you do previous X-ray or CT chest or something, then you can find something like. So the differential will be either something infection like what we mentioned here, or something metastatic,
or other causes of internal jugular vein thrombosis as prolonged catheterization.
Exactly, yeah. So you need like a causes of thrombosis and causes also of neck space infiltration, because here you can see that there is much neck space infiltration, stranding, and so on. So you need to put in the U differential, right? Something either infection, inflammatory, or either right? Okay.
Malignant.
Either malignant, exactly. So we put here in the differential something that it can be okay. So you'd like to continue with us in this case, or there is any other volunteers? This patient is a 40 years male, and he have left painful ophthalmoplegia. And if there is anyone want would like to join us. I think يعني ophthalmoplegia, when you see this clinical, before you see the images, you should think about something. What it could be. يعني just you hear that there is painful ophthalmoplegia, in your mind should be like, and if you are going with MCQ, in the question, you should search for this critical words. If you sign this word or something with this meaning, you should
something in the cavernous sinus.
Exactly. This what we should think about. So something in the cavernous sinus, and that's why when you just see the clinical, you will search for something in the cavernous sinus. So the cavernous sinus should be here. So what you can see in this case?
Abnormal enhancing lesion centered on the left cavernous sinus.
Okay, so you maybe in this sequence, in this image, you can clearly see this. Maybe if you will ask me, I think you will ask me for fat set T1 fat set.
Yes.
I think this is the first one, yeah. So you need this one,
okay.
right? And it will be here, exactly.
Okay.
So in T1 fat set, you saw this, what it could be differential for the cavernous sinus lesion. Cavernous sinus lesion, what it could be the differential. Let's see if they have more.
Either a tumor or an inflammatory condition, or uncommonly metastasis and lymphoma.
Exactly, metastasis and lymphoma. Dr. Ramin also put in the chat some differential very good. Tolosa-Hunt syndrome, meningioma, yes. Maybe, exactly, and metastasis.
Meningioma, schwannoma.
Yeah, exactly. So in this case, as you mentioned, the left side, the left cavernous sinus, and they like it much in the exam because sometimes it's a bit tricky and hidden. And this case is very interesting because this patient underwent steroid treatment. Take a steroid treatment, and after 4 months, he have this picture. So what happened here in this case? What happened? Anyone can chat. We are chatting together, so feel free to just, exactly, there is good response, not just response, there is good response. So nice, yeah, exactly. So let's talk about what it could be the differential and what it could be the case. It's a very interesting case. As one of our colleagues mentioned, that it's Tolosa-Hunt disease, which is non-specific inflammation of the superior orbit. They like it because it's like a bit name which is have pseudotumor Tolosa-Hunt, non-specific inflammation. It is retroorbital and so on. The most important, not just to mention Tolosa-Hunt, the most important to mention, as Dr. Dr. name, your name is, if you can mention your name, meningioma, sarcoidosis, pituitary tumor, TB, and lymphoma. So this is the most important that you mention the differential diagnosis. So let's shift it to other cases. Yeah, Dr. Nirmin. I have like some collection in playlist. This patient come to you by developmental delay, and something very good in Radiology that they give you the clinical. So you are lucky, and this help you if you are going to have FRCR 2A. This help you a lot in the MCQ part and also in the EDIR, because most of the question in EDIR, it have like a clinical history. So don't forget to read it carefully, because most of time it have the key. Okay. Let's go to the images. I think I press to the MRI brain. I'll just try to close the other cases to not take the internet. So if we can make some fun with this case, if we want to make like challenge between two who can come with us in this case, can we have two volunteers this time, one against Dr. Ramin or with Dr. Ramin, to make it more fun? We are just chatting, so yeah. So Dr. Nada mentioned that from the first sight, she saw that the parallel appearance of the ventricles, so it can be like corpus callosum agenesis, exactly. And you cannot stop in this because, as you know, that if you find one abnormality or one anomaly, you should search for others. So don't stop, please. Don't make satisfaction, because if you reach satisfaction, probably you will miss something. So I can see that most of people see that there is something here, yeah, arachnoid cyst, and you need maybe diffusion to differentiate. We will talk about diffusion as someone asked me about diffusion to talk about it, okay? Again, it doesn't, this is much things in this case. So this is a small optic asthma. This is arachnoid cyst. There is bilateral periventricular heterotopia. And this is incomplete fornix in the right side and the communication between the frontal lobe. So don't go satisfied quickly. Take care, because some of these cases, it have many findings. We can try to find at least the axial. So in the optic asthma, check the optic asthma, because you will find that the optic asthma is small in this patient, okay? And this patient, as we mentioned, have arachnoid cyst, have nodular heterotopia. So let's check this nodular heterotopia in the, yeah, exactly, gray matter in the ependymal lining. So the gray matter should be here. So this is like a migrational anomaly to find that in the ventricle, right? Yeah. So Dr. Marwa, you need to see the pituitary gland. So where is the pituitary? This patient also have something in the pituitary, as he mentioned, right? Posterior pituitary signal located in the hypothalamus. That is called, what is called, Dr. Marwa? What is called this?
Ectopic neurohypophysis.
Exactly. Perfect. Nice. So this is like a collection of finding. Don't be satisfied easily, okay? And try to find another and another. It can come to you in a short question. I find like this is a good case for collection. I will share with you in the group all this playlist, so don't worry. I will give you like a good time to read it. I think I can take one here. Also, this is a good example, and one here. Yeah. So this patient swelling in the right side of the neck is age 35, and her gender is female. Okay. Sometimes it can give you like relevant clinical that help you to characterize, and sometimes it doesn't give you something. So let's have a look in this case. And okay, so what? If you find anything, just talk or write or whatever. Maybe it's not easy in T1, or you want me to shift in the coronal stair? Okay. So as you see here in this case, yeah, maybe you should be used to see the coronal, and you don't have to go to the axial. But yeah, so both differential, it can be carotid, body tumor, and the glomus tumor. Especially, I think if you look in the T1, yeah, this one, yeah. So very nice that you put differential, and this differential sure include paragangliomas. Paragangliomas, the same name of glomus. Okay, so if you find this type, it's easy in the, to be honest, in the axial, but in the coronal or sagittal is not very easy. But you should put good differential, especially the carotid body tumor and schwannoma. And yeah, exactly. So be careful in these cases. And I think it have bilateral carotid body. If you find some in one side, go and check for the other side, because sometimes it's bilateral. As is the schwannoma, it can be bilateral also. So yeah, the characteristic to, we mentioned it before, that the characteristic to differentiate between carotid body tumor and vagal, glomus vagal, that it have splaying, who splay and make the both carotid away from each other. This is could be the carotid body tumor who displace both anteriorly. This is the glomus vagal. Okay, so salt and pepper, paragangliomas. Yeah, someone send that it happened like 6%. Okay, thank you. So let's check the answer and see. Yeah, exactly. Bilateral carotid body tumor, right glomus jugular, paraganglioma, and he mentioned also in the differential it can be this. Okay. Let's go to this one. I don't know if it is. Yeah, right chronic suburative otitis media 4 years ago, and he did this. Exam, CT vitreous. Let's have a look. So if someone want to explain, describe. Okay. So if you find something like this, your approach is important to look for the ossicle, right? So this is the ice cream cones. Ice cream cone, and you want to see if the ossicles are eroded or dislocated or whatever. And also try to go to the anatomy of the facial nerve and check if there is any facial nerve erosion, facial canal erosion, or okay. So why you check this? Because you want to see, and also try to find the high resolution images with zooming, because the temporal anatomy is very small, so you should have something that help you. Okay. So I'm waiting if there is any, someone have clue. Is it, I think from this image, someone can tell me what it could be the clue here. I think it is easy one, right? Okay, so this is external ear. Here it should be the scutum, okay, scutum, this triangle, exactly. And this is the middle ear cavity. And the middle ear cavity already, like, there's soft tissue attenuation or hypodensity fulfilling the middle ear cavity from the epitymphanum, mesotymphanum, and the hypotymphanum. Okay, so if you saw this tissue, so you think about with the history that this patient have chronic otitis media, so you think either this is something like infectious chronic otitis media or it is cholesteatoma. And this is the key, how to differentiate between both. You should look for the ossicles. If the ossicle, this is the normal appearance of ossicle, never, no. So look in the ossicle and you can see here the erosion, and also you can see the tegment tympani, which is the roof of the middle ear cavity. And the most important in to prove that is cholesteatoma, look in the other side, which should be the normal side, that the scutum is clearly triangle. So you saw it well. And here you can see, sorry, here in the coronal, you can see the facial canal here, okay, the labyrinthine segment, and you can see here this segment, which is this attenuation or soft tissue density is encroaching upon it, okay? So whatever, here you need just one more image to prove that, or to confirm for you that is cholesteatoma. What could be? you go for MRI and search for, yeah, Dr. Farouk, hey, great. Nice. Right side soft tissue against the tympanic membrane, the middle ear with ossicular erosion, exactly. So Dr. Marwa mentioned that we should go to diffusion, and they here make something like a hybrid imaging or fusion imaging between the diffusion and the cholesteatoma, and you can see that there is a restriction in the cholesteatoma, which is here is colored with orange or red, whatever you like. And this is the original photo, which is the diffusion. When you find this appearance in the middle ear, and this is diffusion sequence, first thing is to think about cholesteatoma. Can I ask what is the link between the cholesteatoma and one cyst we mentioned in the previous lecture? Can someone tell me what is the cyst and what is the link? And I think this is very important in the exam to link between this cyst and the cholesteatoma, because it's the same pathology and the same appearance. No, not cholesterocyst. Cholesterocyst, no. Yeah, it is epidermoid. Yeah. So the cholesteatoma, it is like some pathology or similar pathology to the epidermoid. You can consider it like epidermoid, but happen in the but it is not like this. But I mean, you can consider it like this, the epidermoid. Okay, inclusion epidermoid, as Dr. Nermeen said. So don't forget that the epidermoid and the cholesteatoma both restrict in diffusion, and this is the key to help you to know what it could be. Okay, so whatever you see this appearance of erosion of the ossicles, and especially if you have this tegment tympani, and one of the important things, if it comes to you as a long case, you should mention no tegment tympani erosions, or there is tegment tympani erosion. So you will take mark if you say no, because as you know, in the long question, either in FRCR or in EDIR, you will have like marks if you say no, important no, not just to say yes. Yes, for example, there is soft tissue, there is something here, there is encroachment here, there is, okay, everything is fine. But if you then don't say no, you will take less marks. So be careful to say no for the critical things, okay? Okay, so let's have another case. Any question in this case before we, okay, we close it. So I think also someone, he will like this. Okay, so patient come to you again with sinusitis, and this patient have a mass, and she is female, which is 20 years. So this patient have tender mass, and this يعني very detailed clinical. You are lucky if you have this in the exam. Most of the exam they didn't give you good clinical, so it give you just few clinical, and you should, yeah. So one of our great doctors, they know that, many doctors know this. So what if I ask you, Dr. Ala or Dr. Farouk, Dr. Nermeen, what is the pathogenesis? How it come? This is tumor, Bot's Buffy tumor. What is the pathology? Yeah, it is infection. So this is like misnomer, is something infectious which appears, have it like swelling or something in subcutaneous and extend intracranial. So one of the important marks in this question, if you come to you with a long question, that you should mention that there is intracranial extension or not. Once he mentioned to you sinusitis, it is the same idea like Lemierre syndrome. When you have something infectious, it can extend and it can go whatever it go. So as you mentioned, thank you, very good comment. Thank you for all. Yes, exactly. So don't forget to mention the intracranial extension, whatever it causes, cerebritis, emphysema. Okay. So in this case, as the bone is affected, and you can see how this osteolysis happened, and it can show you this appearance. I think is good case that it can come because they like this type of especially if you mention the differential in this case. But when he give you the history and the clinical, I think it is يعني key to be more concise to few diagnoses. Yeah, I think I open it. Yeah, okay. So yeah, it can be METs. Yeah, it can be METs, Dr. Marwa. Yes, I think METs and lymphoma, it can happen wherever, whenever, wherever. Okay, so this patient, 60 years old male, he have yeah, he have shortness of breath and lymphadenopathy. Let's have a quick view for the images. And this patient يعني did neck and chest, so much images in this patient. Let's have a quick look. Let's scroll and see what it can be. So if anyone get a clue or any finding, just if you'd like to tell us, okay, or to write, okay. So this is the coronal images. Okay. And let's shift to the, okay. So anyone want to tell any finding in this case? I'm just a bit quick to catch as much as we can from the cases. Okay, so I wait for someone to tell us something, or we shift to the finding. So there is some lymph nodes, non-specific, but there is something hilar and something mediastinal lymph nodes, and some centrilobular nodules, okay? And he mentioned that in the sagittal images, which we are here, that there is cellular and supracellular enhancing lesion. So what you would like to do in the next step? Okay, it's good to think about sarcoidosis, but we mentioned this, Dr. Nermin, that يعني don't rush for differential until you get the يعني the complete picture. يعني to not be satisfied easily, and also to not be tricked easy. But I agree with you totally that sarcoidosis, one of the good differential, because we have hilar mediastinal lymphadenopathy and we have centrilobular nodules. This patient, I was waiting to say that we can do MRI, but he did ultrasound. And I think this ultrasound, he take the biopsy from this lymph node because they think that maybe, as you mentioned, lymphoma or sarcoidosis. Yeah, we should mention that it could be also TB or infection as a differential. And I think, in the MRI was a bit surprised, not a very big surprise, but we see that this patient have disappearance. So how to describe disappearance? Exactly, Dr. Farouk. So we have here like soft tissue or thickening of the pituitary and also of the pituitary stalk. So there is enhancement and enlargement of the pituitary stalk. So once you see this, you have your differential in your mind. It should include, as Dr. Shireen said, that it can be sarcoidosis. Yeah, Langerhans, but it need to be younger patient. That's why important to check for the history. How old is this man? How old is was? I think it was 60s, right? So the most important in this case, that to mention that the hypophysitis, which include IgG4, yes, and it can be METs, sarcoidosis. After 1 year, this patient take like a steroid or take something, a treatment, and he resolved completely, as you see in the MRI picture in the sagittal. So yeah, this is what is called lymphocytic hypophysitis. So lymphocytic hypophysitis, it will be good differential in this case. We think about sarcoidosis. Also, you should think about metastasis, but don't forget that there is some very good differential and this very good case for exam. I'm just want to, because I have two options now, to continue in this playlist and finish it, or we have like this slides and finish it, because we have to choose one. To be honest, we already try to cover every important part in the neuro in the 3 lectures before, and this is the 4th one. It will be the last one in neuro, and we'll shift after. So what do you like? If anyone has suggestion, would you like to continue in this, because to take some more from this list, or to shift toward the... Okay, let's take one or few cases from this until you decide. I think is good to be to give you the... Okay, yeah, we will contain neuro, but there is some request that we should stop neuro, and they want to check other. Okay, this patient, 70 years old, okay, female patient, which have sinusitis, and unfortunately is refractory to antibiotic and nasal steroids. I think this case, I hope it can be easy as I expect. It is this appearance, and he make a notation for you to help you with this arrow that there is something inside. So it can come to you as a short questions with differential, and also maybe he can give you another MRI and ask you, yeah. So what first thing, Dr. Amr, that to put fungal exactly, one of the important. So if you will put fungal, as you know, there is non-invasive fungal and there is invasive fungal. Which type you prefer in this case? Is it invasive or non-invasive? Yeah. I think with this central calcification and expansion of the ostium into the nasal cavity, yeah, you look in the bone. If the bone is distracted, so it is invasive. If the bone is not distracted, so it's not invasive. This patient, as you request MRI. So you will find this appearance in MRI. So yeah. So yeah, this patient, the key that in the T2 is hypointense mass. We mentioned it in the before, that when you find like T2 hypointense, which is a bit dark signal in the T2, so go further, that is fungal. Okay, so in the T2, when you find this appearance with hypo intense or dark signal, it is more going with fungal sinusitis, right? We all agree about this, right? He mentioned that the CT calcification, in the CT with the calcification, this could be the proteinaceous material, not the bone. So that's maybe a combination of the sinusitis and mycetoma with no erosion. Maybe he going with invasive fungal disease. So I think if the bone is eroded, so it can be a fungal invasive disease, yes. Okay. So I think it can come to you like a short question, but very, very important to look in this. I think this case, we take it before in our presentation, but let us take it quickly. Important to see or look very carefully in the history, as we mentioned before. Here, HIV. So HIV, when you look in HIV with brain, your differential will be more concised. Okay? Yeah. So brain with AIDS or HIV, you are concised. With some deficient, especially if you find this asymmetrical, not symmetrical, asymmetrical appearance, which look like infarction if you, يعني, or vasogenic edema with subcortical extension. So this patient have low attenuation in the right hemisphere, and there is no contrast enhancement. This is the important, that this patient don't have contrast enhancement. So you don't think about metastasis, you don't think about infection, you think about something else. So as many mention now that it can be BML. I think in the differential, when you mention AIDS, it make you more concise that it can be BML or viral or AIDS encephalitis. So whenever you see this, you go that it can be BML. Yeah, exactly. Yeah. So this is the appearance. He mentioned many. I just want to check if they have. Yeah, exactly, Dr. Naufal. Yeah, viral loads of GC virus. Yeah, this is also characteristic if you check the lab of this patient. And virus load is very important to make you يعني characteristic of this virus and the characteristic of this infection. That is, this is the BML or progressive multifocal leukoencephalopathy. Very important case. They like it in the MCQ, they like it, and they like, we mentioned before, the difference between AIDS encephalitis and BML. It is some sort of demyelination, yes. So يلا يعني let's take the, because you mentioned demyelination in 1 minute. This case it's frequent that everyone sure that he have this in the real life and also in the exam or any exam he have before. This appearance, we mentioned it before, just you see this lesions which is very perpendicular to the ventricles. So you are thinking about something characteristics that it can be MS, right? Yes. And your rule now is not just to mention that it can be demyelinating or MS. Your rule, it should go more further to see, check the enhancement or to check the diffusion restriction. So once you see the diffusion restriction, in this case, you are going not just to tell that this patient is MS, you should go further and tell that the patient is have what? Active MS. Yeah, active MS. Active when you see this abnormal